So how will they describe the clinical presentation for acute pancreatitis? The patient will have epigastric pain, but that pain might be described as radiating to the back. It will not be described as a ripping or tearing sensation, as might be described in aortic dissection, and there will be no abnormalities of the pulses reported. If labs are offered, they will include elevations of amylase and/or lipase. Do be aware, there are scoring systems for the severity of acute pancreatitis which relate to outcomes, but these are not part of the diagnostic criteria. So for instance, a patient might have a high white blood cell count or low calcium level, but these are markers of severity. They are not required to make a diagnosis of acute pancreatitis. The other diagnostic feature includes imaging, which will demonstrate both characteristic features of pancreatitis while also clarifying the etiology, such as gallstones. Returning to chronic pancreatitis, the key features again relate to the many stigmata of fat-soluble vitamin deficiencies. Any of these features may be presented, but those associated with vitamin K are probably most common and confusing to the student. It is a challenging connection between a kid with cystic fibrosis who has diarrhea and the associated elevation of PT-PTT. You simply have to have a heightened awareness of this relation. This slide shows tests for vitamin deficiencies, including retinol or carotene levels for vitamin A deficiency. 25-hydroxyvitamin D, which assesses overall body stores, is the best lab test to assess vitamin D deficiency. Vitamin E is assessed with the alpha-tocopherol level. And do note that B12 deficiency may be seen in chronic pancreatic insufficiency due to lack of tryptase, which frees cobalamin from salivary R protein, permitting the binding to intrinsic factor. And finally, assessing for fecal fat is a key diagnostic test. The initial test would be a qualitative smear for fecal fat. The stool is stained with Sudan black or red, looking for fat globules. If present, a quantitative study is performed, which is the ever-popular 72-hour stool collection. There is a lot of information on this slide. What this should tell you is that the USMLE has lots of sneaky derivatives to test you on with chronic pancreatitis. It is a favorite topic for the test writers down in Philly. As for other diagnostic testing, imaging is obtained, and the characteristic finding, as seen on this CT, is pancreatic calcification. It simply represents dystrophic calcification in a gland that has undergone repeated cycles of fat necrosis. The other key test is a provocative test in the form of secretin stimulation. This is pretty straightforward, and they do like to use it to assess your understanding of basic physiology. Recall, secretin is released by S cells in the duodenum in response to the acid bolus from food that is emptied by the stomach. Secretin wants to neutralize that low pH, so it stimulates the pancreas to secrete bicarb. They will test your knowledge of this physiologic function with the curve shown in this slide. The question invariably shows the response of several electrolytes following the quote-unquote infusion of a substance. A classic question will ask you to name the substance. The answer is secretin, and you will know that because of the elevated bicarb concentration in the pancreatic secretions. So what happens in chronic pancreatitis following an infusion of secretin? Answer, nothing. The gland is dead. A subnormal response is seen. It is a definitive test used to assess the patient who presents with a combination of diarrhea, vitamin malabsorption, and a positive fecal fat assessment. Failure of bicarb elevation in response to secretin confirms the diagnosis of chronic pancreatitis. As for pancreatic neoplasm, we'll again start with adenocarcinoma. These patients are described with epigastric pain, weight loss, and/or obstructive jaundice. How will you know it is obstructive? Pay attention to the description of the stool. It will be described as clay-colored or acholic. That is, bilirubin is not making its way to the intestine to give the stool its characteristic brownish color. Clinically, imaging would be pursued by any of a number of complementary modalities. Do be aware that the mass may not readily be seen, and instead one may only visualize dilated ducts. This is not step 1 test material. Other than for lab features of obstructive jaundice, there is no characteristic lab abnormality for adenocarcinoma of the pancreas. And let's be crystal clear, CA19-9 is a tumor marker used for serial assessment. It is not a diagnostic test. I have seen them use CA19-9 in both directions. That is, they give you a high value in a patient without pancreatic cancer or a normal value in a patient with the disease. Tumor markers are used for mischief and tomfoolery. Don't fall for their little traps. As previously mentioned, MEN is covered in a separate set of videos, but let's review the skinny on gastrinoma. The key feature is atypical ulcers, and you must be familiar with the descriptions which characterize an ulcer as atypical. These include multiple ulcers, refractory ulcers, and intestinal ulcers beyond the first portion of the duodenum. So if they describe a patient with an ulcer in the second portion of the duodenum, they're telling you the patient has a gastrinoma, especially if there are other features present, such as diarrhea. The lab features include an elevated gastrin level, and I do emphasize this should be obtained off of proton pump inhibitors, as use of those agents are associated with elevated gastrin levels in response to the acid suppression. And look what I've discovered again, another use of the secretin stimulation test. Patients with gastrinomas have an increased release of gastrin in response to an IV infusion of secretin, as demonstrated with this patient who presented with abdominal pain and diarrhea. So this is the second indication for secretin stimulation, the other being assessment of bicarb secretion in chronic pancreatitis. The other big ticket item here is to remember that gastrinomas are located in the pancreas, not the stomach. Normally, gastrin is released from G cells located in the antrum of the stomach. However, a gastrinoma is a neuroendocrine tumor of the pancreas. It is not located in the stomach. The second most common neuroendocrine tumor is the insulinoma, characterized by low glucose and high C-peptide. Recall, C-peptide is cleaved from proinsulin and is used to distinguish hypoglycemia from an insulinoma from exogenous insulin administration. This slide also lists, as a reminder, the common presentation for the other components of MEN1, including hyperparathyroidism and the pituitary adenoma. Two interesting notes on hyperparathyroidism. Recall that the bony manifestations are described by subperiosteal bone resorption. That is a unique description that you really need to become familiar with. The other thing I realized while writing this section is that although hyperparathyroidism is associated with nephrolithiasis, I don't think I've ever seen a question on that connection. That's crazy. As for pituitary adenomas, they will generally be described by mass effects such as headache or bitemporal hemianopsia, or signs and symptoms of a prolactinoma such as galactorrhea in women or hypogonadism in a man. So we are left with the last two considerations, complications and pathology. Of course, pathology is the granddaddy of all modifiers. For the pancreas, however, it plays a lesser role, with only a couple of exceptions. So they won't ask you to choose ARDS as a complication of acute pancreatitis. Instead, there will be a pulmonary question where they describe a patient with ARDS. The predisposing condition is acute pancreatitis. Be aware of this association so you're able to answer the ARDS derivative. In this example, the derivative is a pulmonary question on ARDS addressing the pathologic description of hyaline membranes. They used pancreatitis to get you there. And here are the two characteristic pathology descriptions to be familiar with. Acute pancreatitis is the prototypic condition for fat necrosis as opposed to coagulative or liquefactive. The necrotic tissue can undergo dystrophic calcification that may be described as white chalky deposits. The other key piece of pathology is the description of a pseudocyst. So what makes it a pseudocyst? It is the lack of epithelial lining. The cyst wall is composed of fibrotic granulation tissue, not epithelial cells. They love this little gem. Insofar as complications of chronic pancreatitis, there are both exocrine and endocrine dysfunction. To treat the exocrine dysfunction, supplemental pancreatic enzymes are given with meals. And with extensive pancreatic destruction, diabetes mellitus may develop. And this is a classic question. Patient with signs and symptoms of exocrine dysfunction is at risk of developing which complication? Answer, diabetes. I do highlight again the weak association between chronic pancreatitis and adenocarcinoma. We are winding down, but please stay focused on this association that regularly escapes students. Adenocarcinoma of the pancreas is associated with the important paraneoplastic syndrome of migratory thrombophlebitis. The patient will be described with a self-limited clot that resolves in a couple of weeks and then goes on to develop another clot. Of course, they won't say clot. They'll describe signs and symptoms such as asymmetric redness, swelling, and pain. This is the tricky part. Clot develops, clot resolves, clot redevelops. You won't know what they're talking about, but the question will ask the most likely underlying cause. Answer, adenocarcinoma of the pancreas. On the subject, let me just remind you of the other malignancies associated with hypercoagulability, which are the favorites of the NBME, P. vera and renal cell carcinoma. The clots associated with P. vera seem to come up in the liver section, including Budd-Chiari, which describes a clot in the hepatic vein, or they might be described with portal vein thrombosis. Renal cell carcinoma is generally presented with a clot in the left renal vein, and which may be described by a new varicocele in the male patient. And here is a summary slide of our journey through epigastric pain, but hang in there for one more second. I've included index card summaries of the materials just covered. I do encourage students to take less notes, not more, and they always ask the follow-up question: what is the material I need to know? This is summarized on the next 3 slides for your convenience. Here is acute pancreatitis, chronic pancreatitis, and the pancreatic neoplasms. And that concludes our symptom-based review of epigastric pain with a focus on the pancreas. If you have any questions or concern about this content or how to make a delicious White Russian when you celebrate completion of Step 1 studies, please email me at 12 days in March. Thank you.